Good afternoon, one and all. It gives me immense pleasure to welcome you all to the second week of this faculty development program. Today, we are honored to have with us Mr. Prakash, Associate Professor in the field of Orthopedics Physiotherapy at KMCH College of Physiotherapy. With 18 indexed journal publications, including one copyright, he is an author of few books for arthritis patients. He has over 18 years of experience and received many awards. Today, he joins us to share his insights and expertise. We invite you, sir, to talk on outcome measures for low back pain.
Good afternoon, one and all. I'm audible. I'm audible. Okay, thank you. It's both honor and privilege for me. First of all, I would like to thank my principal sir and vice principal madam, and organizing secretary madam, and my department senior faculty Siva sir and other faculties. Today, my topic outcome measures for low back pain. Myself, Professor J. Prakash. I'm Professor KMCH College of Physiotherapy. Outcome measures for low back pain. Shall I continue? Everyone audible? I'm audible. Hello?
Audible, sir.
Okay, thank you. So the purpose of the knowledge is action. Action always speaks louder than voice. So knowing is not enough, we must apply it. Willing is not enough, we must do it. So I request all the participants after completing this FD programs, please whatever you learn from outcome measures here, you go and apply in your clinical setting as well as you go and you must do lot of research work with help of this outcome measures. So whenever I am going to talk about research topic, I always remember this குறள் திருக்குறள் எண்ணென்ப ஏன் எழுத்தென்ப இவ்விரண்டும் கண்டென்ப வாழும் உயிருக்கு. So எண்ணென்ப means quantitative, எழுத்தென்ப means qualitative. So Thiruvalluvar mentioned these are the two wise, the wise declared to all on the earth that live. So I move on to topic. So low back pain is a global problem. LP is a very common. At least once in your life, everyone experience low back pain. So it's a very costly problem. Why I mentioned for costly problem? They are going to spending lots of money for medicine as well as investigation procedures, surgical procedures, and rehabilitation, and other lot of things are there. So it's always costly problem. 619 million people around the world have low back pain. So according to the systematic review, LB is the single leading cause of disability worldwide. The highest number of age affected in this low back pain is very commonly 50 to 55 years. And non-specific low back pains are so common. 90% of the low back pain comes for non-specific low back pain. Females are more commonly affected. So before going to start my outcome message, just I'm going to give some brief idea about back pain. I mentioned already the specific pathology, it occurs only for 5 to 10%, like fracture, disc prolapse, stenosis, and list disease. Undiagnosed low back pain, that means non-specific low back pain for 90% cases. The serious pathology for only 1%. Whenever I talk about low back pain, you should come to know what is the core muscles, superiorly diaphragm, inferiorly pectoral muscles, anteriorly transabdominis, and posteriorly multifidus. For disc prolapse, how will you simply differentiate from differentiate means whenever any patient come and complains bending forward, pain aggravates, and more think about disc prolapse, to focus on McKenzie approach as well as multifidus muscle. If a patient complaining pain when bending backward as well as standing, prolonged standing, calf muscle pain means that most of the time you can suggest, expect for stenosis kind of problem. You focus on mainly for transabdominal muscle as well as Williams type of exercise. So pain I am going to divide into two acute pain as well as chronic pain. Now is appreciated more on biopsychosocial model. Chronic pain always varies from person to person. It always individualized. That means only one causes like right pictures. See, only one cause is going to create problem. If you compare with chronic pain, there are multiple factors going to involve like arranged marriage, So chronic pain varies from person to person. It always individualized as well as unique. In American Pain Society in 2003, the statement given with the fifth vital sign. Already we know four vital signs are there. They are considered as a pain also one fifth vital sign. So also one famous quote is there: nobody is superior, nobody is inferior, but nobody is equal also. People are simply unique, incomparable. That means you are you, I am I. That means the same kind of treatment not suitable for everyone, the same kind of assessment suitable not going to suitable for everyone. So we can go select for outcome measurements according to the patient's need as well as the quality of uh, life. So see this diagram, how acute pain was converted into chronic pain. The same size of circle only in left side and right side. But see the nociception out and the pain behavior is changing. Acute pain nociception will be more when compared with pain behavior and pain suffering and all very less in acute pain. When come for chronic stage, there will be pain behavior and suffering that are all more in chronic pain. So that means it's going to affect biological as well as social and psychological. So I always called as a toolbox. So after this FPTP, you should carry not only for goniometry measuring range of motion, stethoscope, and reflex hammer. You should always carry for toolbox like outcome measures also. So what Oxford English Dictionary mentioned as it's nothing but it's a visible or practical result. So most of the time we called as paramount for medical practice outcome measures. It's going to be helpful for clinical audit as well as research work. So, what is the main purpose of uh, for using outcome measures? It's going to setting the standard of care. Take example of back pain. We should which type of therapy we are going to implement. We are normally standardized. We are going to give for subgroup for four groups. Like who is ideal candidate for manipulation, who is ideal candidate for traction, who is ideal candidate for exercise like extension type of exercise or flexion type of exercise, who is the ideal candidate for stabilization. That and all how we are going to confirming means with the help of these outcome measures only. Then we can as well as we can stand setting the standard of care as well as we are going to measurement also whether it's going to good result is giving for better improvement or not. And the other thing is, it's going to assess the disease, assessment of the disease, whether it's an acute stage or subacute stage or chronic stage, is a recurrent or whatever it is, we are going to confirm with the help of outcome measures only. And we are going to check for injury severity. That means whether it's a mild, moderate, severe, that and all we are going to confirm with outcome measures only. So I always called as a outcome measures a clinical companion. So most of the time I always mention for your goal select for outcome measures for objective type only. But subjective type also is very effective. We'll see how upcoming slides. I'm going to explain how subjective tools also going to effectively works. For last decade, the use of this instrument and questionnaires in particular has been intensely promoted by authorities in the field of uh, clinometrics. So in such names, they called as the index, outcome scale, instrument, score, profile. There are different types of names. Finally, 1987, the Feinstein, for avoiding ambiguity, he suggested the index as the preferred term to be used for commonly used for this outcome measure. That means outcome index. They called as outcome index the correct terminology. So coming for my topic, low back pain, biopsychosocial. Low back pain, I already mentioned there are different types of. There is not going to cause us one problem for low back pain. There are multiple factors going to involve multi-dimensional problem. So we are our outcome assessment also should be multi-dimensional. However, no instrument or questionnaire exit cover all these aspects. This means that the use of questionnaires will always mean a set of questionnaires rather than a single instrument. So we should not measure for everything. That means if we take for chronic pain or low back pain, so, sometimes we can measure the quality of life. Sometimes we are going to measure for the functional limitation and pain and negative impact and lot of things are the fear avoidance questionnaire is there. So a lot of things we are going to include. So we should not cover everything in one single questionnaire. So why we are using for outcome measures? Why we are using means what to do to assess. That is very very important. In order to understanding the impact of low back pain patient's life, clinicians require is a reliable and valid and responsive measurements tools mainly to accurately assess the function as well as monitor change over the time. So why we are using for this outcome measures means they did one study In that study, they concluded high quality care for all. That is ultimate aim. When using for quality of the standard outcome measures, if we are measuring using means we can use for high quality. We can give for all over the people, all over the patient. So it was stated that outcome measurements are to be used to determine the quality of service to all. That is the main thing. So I told you, no, objectives only reliable, whether subjective also reliable or not. Yes, subjective also reliable. When means a well-developed and responsive outcome measures provides the beneficial information to determine real change and evidence of treatment and effectiveness. So how to select for outcome to outcome measurements means, so according to that, first you check for health condition and problem, then you can classification, subclassification. That means back pain means subclassification, whether it's acute or chronic or subacute. Then you can go with ICF model, body structure and function and activities and problem in participation and personal factors and environmental factors. So step 2, treatment goals. You set the treatment goals on different domains, whether you are going to check for pain, whether you are going to check for functional limitation or health, high quality of life. So you can set for different domains and select for according to that. You can select for outcome measures, and methodologically you check for whether it's a quality one or not. Then you can check for feasibility also. Finally, then availability also very important. Certain things we can paid version also is there, you can check that also. Finally, once you confirmed this the particular outcome message for your research work means, you can apply it and collect data and finally interpretation and conclude your outcome measures. So what I'm going to start with, it's very short duration, so I can't able to cover for all the outcome measures index here. According to the, I'm going to present one case. According to that case, I'm going to talk about certain outcome measures. A 30-year-old gentleman with intermittent low back pain since age of 15 years, and he had recent relapse of acute low back pain. He started 2 weeks previously when he get up from the bed. The previous episode of low back pain was 6 months ago. There was no radiating pain. Limited activities for aerial activities as well as sports, especially for tennis. He was a sick leave applied for last 2 weeks. The patient is convinced that continuing work will cause his health and deteriorate, is worrying about his prognosis. He has not improved and has been referred by his general practitioner for physiotherapy treatment. The physical examiner reveals no red flags. Here I want to ask one question. What is meant by yellow flag? Please, anyone please answer me. What is meant by yellow flag? Anyone have idea about yellow flag? Okay, yellow flag means nothing but so psychosocial issues. Psychosocial issues. Very long back, I thought yellow flag means relative contraindication. That is totally wrong. Yellow flag means you should focus on more on psychosocial issues. That means they will go and get more information from Google and come according to that they will think about they have more problems. That means if a patient have some headache means they think they have some problem in head means they always think about tumor like that. So yellow flag. So it is concluded that the patients has begin a specific, this particular patient have begin a specific low back pain. So according to ICF model, so what is the body function and structure here? The low back pain for 2 weeks, there was no radiating pain, no indication for red flags. What are the activities here? Limited in activities daily living as well as sports and work. So participation, he has relapsed for 2 weeks ago, is not participating in sport as well as he is not working properly. So external and personal factors here, the patient has some negative cognition. That means concerning the influence of working is prognosis. Very important thing. Please remember, participants, negative cognition is also very important. For particularly for in this case, the patient has already had 15 years intermittent low back pain. He thought already, and he has not improved over the last 2 weeks. He has not continued working. He is worrying about the prognosis. There are negative cognition. So what is a good outcome instrument? Most of them thinking, then how will I confirm whether it's a good instrument or not? So the instrument chosen must be reliable. What's reliable? It reproducible the result. Then it should be valid. What is meaning by valid? The measure what they intend to measure, and responsiveness, able to detect the changes over the time, to be able to evaluate the effect of treatment. So what are the other qualities of good outcome instrument mean? The feasibility is very important. Not take too much of time and should not be too expensive And last but not least, very very important is available in the appropriate language is very very important. Participation, I request you all to do lot of study in this area. You can convert according to our local language, for Tamil or Telugu or Malayalam or Kannada, whatever it is, you can convert certain important questionnaire, then you can get copyright and they'll do lot of research work, and you can publish also. Very very most uh, work we can done in this area. So last one is the therapist must be able to interrupt the result of treatment. That is very very important. Finally, so according to International Association for the Pain, for the study of pain, here I am going to give divide into three categories. First one for pain, second one for functional limitation, that means disability. Disability we should not use the word, it's called differently able now. So last one is for health status, that means generally for quality of life. For pain, I go with VAS scale, and the functional limitation, I go with the Hospitality Disability Index, and quality of life, I go with short form health survey 36 and 12 or 10 items. So what is mean by pain? I'm going to fastly revision what is by pain. Pain means Latin word. It's a punishment. We call it as a pain. What are the known to unknown means? We always think about pain is a subjective until it's acute. Once it converted to chronic, we should not call it as a subjective. There are other multiple factors. We call it as a, once it converted to chronic, we call it as a condition. We're not supposed to call it as a pain. We call it as a condition. There are other factors. That means biological, psychological, and social factors going to involve. And acute pain means well-defined time of onset. In chronic pain means time of onset sometimes well-defined. So in acute pain, the pathology is often identifiable, and many, chronic pain may not be identifiable. Pathology we can't identify. So primary involves individual, mainly for acute pain, mostly for individualized. Chronic pain is individual, not only for individualized, as a family and working place and social network and social issues and other things are going to play major role here. So in acute pain, we are focused only for biomedical approach. In chronic pain, we are focusing on biopsychosocial approach. So these are the main thing. In acute pain, we are focused on impairment and functional limitation. In chronic pain, we are mainly focusing on functional limitation and disability. So here one teacher 1959 stated one quoted one statement. It would be wonderfully helpful to have objective signs of subjective changes, but it seems unlikely that many such aids will be readily available in any precise way for years to come. So till we are using for same kind of tools only, we are not focusing on multidimensional. One of the famous tools I am going to explain now, visual on our scale, is most commonly used to instrument as a mainly for quantity of pain. We are going to measure it with the help of our scale. It's a continuous scale. It consists of straight line, usually for 10 centimeter length. One left hand we called as a no pain. Right hand is called as a worst pain ever experienced. You should explain patient before going to give this tool. The orientation of the line maybe you can use for vertical as well as horizontal, no problem. Scoring takes place less than 1 minute, and training of patients and therapists is not required. The simple one only. Once patient mark, after that you place for 10 centimeter scale and we can take it whether it's 7 or 5 or 4. According to that, we can take it for pre-test. So I'll give intervention. After that, we can compare with post-test also. The main advantage of VAS scale is very simple and quick to score, to avoid precise descriptive terms, and also provide many points from which to choose. So here was one study done. Reliability of the VAS for acute pain measurement as assessed by ICC appears to be high. 90% of the pain rating were reproducible within 9 mm. These data suggest that the VAS is sufficiently reliable to be used as assessed as acute pain. So test and retest reliability, correlation 0.99, and concurrent variability based on the correlation between the VAS and finger dynamometer, correlation 0.87. The finger dynamometer is a device that registers the amount of force exerted the individual believes is comparable to the pain intensity. The correlation 0.81 to 0.87 was found between VAS and verbal description scale of pain. So recording responsiveness of VAS, it has been found that the VAS is able to detect 21 levels of just noticeable differences that individuals are able to detect. So next I move on for Miguel pain questionnaire. So most of the pain questionnaires, there are other different types of pain questionnaires are there. Most of them they only focus on only for quantity. So measuring the just one dimension is not enough. So it's like specifying the visual world in terms of light flux only. They are not bothered about pattern, color, texture, and many other dimensions of the visual experience. I told about Millsack 1971. So one method of pain measurement that overcomes this all problem is Meckel pain questionnaire. So in this method, the 78 descriptors are divided into 20 subgroups to reflect three dimensions. That means pain, that means sensory, 10 words, affective 5 words, and evaluative for one group that are appropriate. Skip the inappropriate set. The questionnaire can help three major measurements. That means sensory. Sensory means they are focusing on mainly for sharp pain and acute pain, aching pain and burning pain, this and all. Affective domain, they called as an emotional response to pain, sickening, frightening, and tiring. Evaluating, that means with the help of VAS scale, we are going to check for intensity of the pain here. So it was developed by Dr. Millsack at McGill University, Montreal, Canada, has been translated in several languages all over the world. It's almost 5 languages. They translated this scale. So mainly they focus on what does your pain feel like, how does your pain change with time, and how strong is your pain. So cumulative calculation is in a pain rating index. So McGill pain questionnaire takes 5 to 10 minutes to complete. When administered every 2 to 4 weeks, it has demonstrated changes in status very clearly. So this is a Meckel pain questionnaire, patient name and date and time, and a PRI, the 1 to 10 for sensory, 11 to 15 for affective, and 16 for emotional. Like that, there is according to the patient appropriate word, they will select. According to that, they can calculate the score. So here there are three way you can calculate the pain rating index, which is based on the sum of the scale values. All of these were chosen either given category. That means sensory, affective, evaluating. Second method is for ranked score. That means sum of all ranked values within each group of words chosen can be computed for the total questionnaire or for each of the dimension. The third measure is the total number of words chosen. The rank is most commonly used to measure due to its simplicity and sensitivity. So here was what study was done. The validation of the short form Meckel questionnaire considered together with the results for other recent studies, the data suggests that short form Meckel pain questionnaire can provide a valid, responsive, and efficient assessment of both neuropathic and non-neuropathic pain qualities for clinical trials and other clinical research, examining a patient with various acute and chronic pain conditions. So I told you it is a multidimensional approach. Sometimes some disadvantage also is there in this method. It's a very complex one, more time consuming. That means more than 20 minutes it takes. Other thing is already you have reliable and valid tools available for fast scale. So no need to much worry about this kind of tool. Sometimes it's unsuitable for very sick patients. The time involved in the assessment has limited its application in the acute pain setting. Uh, and some words are described sensory qualities of the experience in terms of temporal, spatial, pressure, thermal, and other properties. Words that describe affective qualities in terms of tension, fear, autonomic properties that are the part of pain experience. Evaluate words that subjectively describe the overall intensity of the pain with the help of Oscar. So a short form Meckel questionnaire. Here, the shorter version from the Meckel pain questionnaire was developed in 1987. The pain rating here for two subscales only. Sensory for 11 words, affective for 4 words. So these words are items are rated on an intensity scale. 0 means none, 1 mild, 2 moderate, and 3 severe. There was also one item for present pain intensity and one item for 10 centimeter was scale. And short form Meckel pain questionnaire was further revised in 2009. Mainly they done study with help of in condition like neuropathic and non-neuropathic pain condition. So new version available, only 7 additional symptoms are related to neuropathic pain. The total item was 22 items, 0 to 10 as well as numerical pain scale. So this is for short form Meckel questionnaire. Here also some words are there: thrombing, shooting, stabbing, like that. Left hand is no pain, right hand is for worst possible pain. And PPI, present pain intensity, that means 0 means no pain and 5 means a short form Meckel pain questionnaire is now used frequently for clinical practice and research trials. So reliability in terms of correlation between scores before and after treatment were high. The Meckel pain questionnaire has been validated on very different population against VAS for pain with correlation coefficient varying from correlation 0.452 to correlation 0.79. However, the more concentration and coordination are needed in the study, and this can be difficult post-operatively in patient with neurological condition also. It's very difficult to use for post-operative, immediate post-operative as well as some neurological condition, because some patients they have very little bit of drowsy or other coma level and other factors are going to uh, involved in this time. So next I move on for functional limitations or disability. Here we are going to use for associated disability. It is very commonly used disability scale. Here we are going to design to give information as to how your back trouble has affected ability to manage everyday activity. That means with help of back pain, what are the difficulties you are going to face the particular time, how it's going to impact on your ADL activities. So here this scale also we called as a patient reported outcome measures. Always mark one box only in each section. The most closely describes you today. That means today what you are going to feel. According to that, you can select for one thing in that. See, this is for scale. Sorry, sorry. Oh, see, Oswestry Disability Index. So it says one is pain intensity, personal care, lifting, walking and sitting and standing and sleeping and sex life and social life. So like that is there. So each questionnaire gives user details on one low back pain patient overall everyday functioning. So how at the time of pain, because of that pain, how your radial axis is going to affect. We are going to check with help of the scale. The sixth response is there. One is pain intensity, self-care, lifting, moving around, sitting or standing, sleeping, sex life, social life, and travel and transportation. Here 0 means denotes absence of pain related restriction, where 5 means it denotes highest perceived pain restriction of an activity. Some literatures we called as Oswestry low back pain disability questionnaire. Sometimes they called as OLBPDQ also. The same Oswestry ODA only. So here the study was done reliability and validity of Oswestry disability index among patients undergoing lumbar spinal surgery. Here concluded the Oswestry disability index is a unidimensional and internally consistent scale that can be used to assess the severity of the disability in patients undergoing lumbar spinal surgery. In this study, the population, traveling, social life, sex life, personal care were the most important items to define the severity of the disability, while walking and standing were the least important items. So here I'm going to explain how we are going to scoring. For each section, we are going to total 5 score is there. If more, suppose unfortunately, sometimes the patient mark for more than one box in that particular section means you always take for highest value. That means patient may mark for 3 and 4 means you take for 4, you take value for 4. If all 10 sections are completed, though the score is calculated with 60 or 50 into 100. That means 32%. If one section is missed, suppose if you want add not add interested with sex life, then how we are going to mean you can reduce for five items. That means 45. If you not include for social life means you can remove one more column. Then you can use for 40. So like that also you can utilize this scale. That valid only. No problem. If you want to consider only 5 subscale means you can use it for 5 subscale. If you want to use for 6 means 6 you can use it. The entire scale also you can utilize. If you want to remove one segment also you can remove it, no problem. And so on. Such if 2 or more sections are omitted, the percentage score is obtained by the same method. So interpretation 0 to 20 minimal disability, 21 to 40 moderate disability, like that 81 to 100 percentage bed bonding, called as a bed bond. So according to the study, the group mean construct validity, test reaches validity, and internal consistency was high. You can use this tool for measurement of functional limitation. So next I move on for Arnold Morris disability questionnaire. Oh, what is this means? Whenever your pain hurts, back pain hurts, you may find it difficult to do some things normally. Because of pain, you are not going to do your work for normally. So that 24 hours, that means very important. Please remember the past 24 hours, how pain going to interrupt your radial activities. Only you take only considering past 24 hours, not more than that. So, RDQ is derived from sickness impact profile, a general health questionnaire for several syndromes and patients groups. It consists 24 items. You can give only for yes or no question only, closed type of question. There are no specific subscales. Here I show the questionnaire. So like this, 24 question are there, whether you can give yes or no. According to that, you can complete the questionnaire. It's not going to take much time, 5 to 10 minutes only it's going to take. No specific knowledge for training required for the examiner. The questionnaire is scored by adding up the number yes answer, varying from 0 means no disabilities at all, 24 means severe disability. The format, the questionnaire include 24 statements. Respond indicate whether each statement is true, or true means you can give yes, not true means no. Only you consider only for past 24 hours, not more than that. So each yes scored 1, no means respond to no points. The total score was 0 to 24, high score indicating greater disability. So purpose is designed to measure the extent to which low back pain interface with which factors more involved, more affecting the particular radial activities. We are going to confirm with the help of this tool. It can be used for both clinical practice as well as research. So test reliability for same day correlation 0.91, 0.83 over a period of 3 weeks. Inter-observer reliability has been demonstrated to be good, and for determination, consent validity has been correlated with several other index are proven to be good. 0.80 correlated with cubic back pain disability. And responsiveness is demonstrated by an effect size 2.202 in the improved group and 0.41 in the not improved group of the patient. So receiver operating this character is very important for selecting output measures. Is very, very important criteria. Or area under the curve, ACU, they mentioned for ACU, area under the curve, 0.93 also demonstrating a very good responsiveness. So here was one study, Ronald Morris disability questionnaire, Oswestry disability questionnaire, and Quebec back pain disability questionnaire, which has superior measurement properties in old adults with low back pain. What they concluded, the ODI and the Quebec and Ronald Morris have similar measurement properties in older adults with low back pain. So I finally move on for Quebec back pain disability scale. Here we have 20 item questionnaire is going to concerning the activities of daily living related to back pain. The items are selected from 6 relevant subdomains, functional abilities for patients for low back pain, bed rest, sitting, standing, walking and moving around, bending forward, lifting and heavy object. Here mostly we are using for chronic work when patient. Time takes only for 5 to 10 minutes. So this was a question Quebec. So this was a question. So scoring Likert scale is the sum of all items. 0 means no disability, 100 means maximal disability, interconsistency good, test disability 0.90, and intra-class correlation coefficient of 0.90. Consent validity is calculated when correlated with the Ronald disability questionnaire. The responsiveness, the correlation with changes scores on the other questionnaires, longitudinal consent validity has been calculated. So next I move on for some negative prognostic factor, that means Tempa scale of kinesiophobia. The Tempa scale of kinesiophobia will developed Miller et al. 1991, measuring the fear of movement. Kinesiophobia. Low back pain I mentioned, there are a lot of psychological factors involved, false belief, fear, movement going to aggravate the symptoms, and there are other factors. These factors we are going to measure with the help of Tempa scale only for kinesiophobia. That means fear of movement. The questionnaire consists 17 statements. The patient is asked to single to extend the which they agree with each statement using 4-point Likert scale. The questionnaire now takes about 5 minutes to complete, and the score for the items 4, 8, 12, 16 are to be reversed when scoring, and total scores varies between 17 to 64. The normal value is 37. More than 37 is called as pathological. This is for Tempa scale. So purpose, the scale designed to evolve the fear physical activity due to the belief that such activities may cause us further injury. They thought whenever patient imagine the bending forward going to aggravate the symptom, false belief. The original TSK consists 17 items. There is also shorter version is there, 11 items only. Highest score indicates greater level of kinesiophobia, that fear of movement will be more. The scale can help healthcare providers to identify individual who may benefit from psychological intervention and specific rehabilitation strategies. So we are going to add with the cognitive behavioral therapy and other therapy. We can confirm with help of this temper scale. We can use it. So test retest reliability reached Sperman correlation coefficient 0.76. Consent validity was investigated by calculating Sperman correlation coefficient with peer avoidance belief questionnaire, and validation of the TSK with other psychological instrument resulted in significant correlation. In cross-sectional study of chronic low back pain patients, TSK scores were best practice predictor of disability, explaining 13% of variance compared to 4% explained by pain and gender. The psychological factors I told you now, where suppose we want to do for therapy, manipulation therapy for low back pain means we should confirm it whether is a patient have any fear advance questionnaire method. Within this score, patient scored more than 70, we should not apply for manual therapy. That means pain rating below the knee joint or internal rotation, hip internal rotation, restricted more, and these kind of things. We should acute pain, more, that means patient pain for very acute. Like that means we should not apply for manipulation. That means L5S1 manipulation. So this is very important factor before going to apply for manipulation. For L5S1 manipulation, you want to choose mean you always use for the scale fear avoidance belief questionnaire. They are going to divide it two category: fear avoidance belief questionnaire for work and fear avoidance belief questionnaire for physical activity. Like that, they will divide it into two categories. So this is for physical activity. This is for work. Two scales are there. So see, fear physical activity subscales are there, physical activity work scales are there. So in physical activity, evaluate the extent to which individuals avoid physical activity due to fear of movements, pain. Here fear avoidance belief questionnaire, what subscale means, here we are going to assess the belief that works may aggravate their conditions. So identify the patients at risk for chronic pain disability. We can tailoring the therapeutic intervention, whether we can apply for manipulation or not, and other therapeutic interventions, and monitoring the changes in belief and attitudes over the time as treatment progress. So general health, it's very common tool we are using for short form 36, short form 22 is a widely used patient reported outcome measures designed to assess health related quality of life across multiple dimensions. Thus, in psychometric properties, reliability, validity, response, and have been extensively studied to ensure suitability for research and clinical practice. So, this is for short form 36 questionnaire. So, many indexes are available to measure general health perception. One of the most intensively investigated and frequently used questionnaire was SF36. It was designed for medical outcome studies and contains 8 subscales. That means physical functioning, role of physical, bodily pain, general health, vitality, and social functioning, role of emotional and mental health. So they are divided into generates physical component summary, that means PCS, and mental component summary. Internal consistency was shown to be good, and consent validity is tested in many studies and many population, and is in general the sufficient to good and depending upon the method of evaluation. So responsiveness has been tested extensively and has been demonstrated to very acceptable. SF36 freely available version is freely available is there. We can be scored online itself. The process takes only less than 5 to 10 minutes. The result of each subscale in number as well as in histogram related to the reference group is provided. So SF2012 also is there. Same like only 12 items only is there. Completion time take only if you want to complete very fast, we have very minimal time, you want to complete your assessment quickly means you can use this tool. It should not take for 2 to 5 minutes. Like SF36, SF12 can be scored on the scale ranking from 0 to 100. So the SF36 has been strong psychometric property across diverse population, making it be reliable and valid tool for addressing health related quality of life in both clinical and research setting. So finally, I am going to move on for next two important scale, pain self-efficacy questionnaire. So this is very commonly used nowadays. A lot of research is going on this questionnaire. The rate of how confident they were at the time of despite presence of back pain. When patient have back pain, how confident they are. That means 0 means not at all confident. 6 means completely confident. So here is a scale. So this is a scale. 0 to 60s are there. The pain self-efficacy questionnaire is one of the most used self-efficacy questionnaire in clinical setting for musculoskeletal disorder. 2021, one study was done. The recent Delphi method preferred the use of this questionnaire for assessing self-efficacy for over 4 other possible questionnaires. So you are going to achieve goals, and you can give for better treatment as well as greater functional physical functioning. Measuring and improving someone's self-efficacy may therefore important throughout the rehabilitation. Very, very important. So how confident they are, with the help of this we can continue our treatment. So here is the validity and reliability. Is the external validity is been adopted, validated for 14 languages. Both structural validity and content validity of the pain self-efficacy questionnaire are strong. Construct validity reveals low to moderate relationship. Both internal consistency and test intertest retest reliability were very good. The pain self-efficacy questionnaire is responsive to clinically significant change over the time. Scoring, the consists for 10 items. 0 means not at all confident, 6 means completely confident. Pool to estimate the minimal detectable changes 11.52 and standard error means 3.37 were found to be satisfactory. Uh, Patients with chronic low back pain had minimal clinically important difference ranging from 5.5 to 8.5 out of 60 points, while in another study, 9 to 11 points on the FSCQ corresponded to the MCID, which is lower than the MDC, detectable change, minimal detectable change, indicating that researchers and clinicians can replace MTC to GOG changes. Based on these findings, practitioners can confidently administer this questionnaire to assess the patient pain self-efficacy. So how confident they are at the time of back pain, that is we are going to assess with the help of this tool. More recently abbreviated version, the pain self-efficacy questionnaire were developed where only 2 or 4 questions must be answered. Uh, Robust measure of pain self-efficacy may be suitable for use in clinical and research setting. PSEQ2 and PSEQ4 for chronic low back pain showed minimal clinical important difference for 1.5 points. Severe sensitivity of the FSEQ is reported to be 50.7 sensitivity and 84.4 specificity. When using for FSEQ4, sensitivity value is 80.3 and specificity for 68.7. So next time move on for one more scale, the patient specific functional scale. Here we are going to check for determining the functional status of the individual patient. Individual patient. So here we are going to measuring for 3 activities at the time of back pain assessment. So result of back pain rate as activities 11 points from 0 unable to perform the activity, 10 fully perform the activity at the same level of before back pain. At follow, patients were allowed to assess the original scores, were invited rescore each activity according to their current perception of their performance. So validity and reliability was also good. Scoring interpretation, 5 critical tasks you should give. They are unable to perform and experience difficulty with result of their issues. So 0 means impossible to perform the activity, 10 means possible to perform the activity. Highest score indicating better function. So advantage of using for FS pain uh, pain specific functional score. Individualized nature makes it flexible and relevant, suitable for diverse patient population with varied functional goals, sensitive to change and making it useful for monitoring progress. PSFS exhibits strong psychometric properties, reliability and validity and responsiveness make it valuable tool for assessing patient-specific functional outcomes. It is individualized approach, enhance relevance and specificity, although it may limit comparability across the patient. When used appropriately, the pain specific functional score provides meaningful insight to the patient's perceived functional status and change over the time. So finally, I am going to complete with the help of one study, the many outcome measures and chronic low back pain, evidence robust measurement properties and clear understanding of score changes in patient-based measures are essential for clinician to use this data to target the most appropriate treatment, to monitor the subacute effects of treatment that will improve treatment outcome for the patient low back pain. So, in this current investigation, the MCID was greater than the SDC for numerical rating scale PSFS, which suggests a score changes 4 points on the NRS and 2 points on the PSFS are associated with clinically important changes. Scores less than this are associated with measurement error. Based on this ROC curve analysis, FSPS and FSEQ were more responsive than the numerical rating scale, and Ronald Morris disability questionnaire and Oswesti disability questionnaire to detect the clinically important changes in patient with low back pain. Thank you. Sorry, because of short time, I go through very fastly. If you have any doubt, it's only for eye opening only. I there are a lot of other questions are there, but because of time consume, I'm not complete everything. If you have any doubt, please ask me.
Thank you for having you, sir, today for today's session. Really, it is very insightful and inspirational for everyone to learning from you and from your expertise. So, dear participants, please post your questions in chat box or unmute yourself and ask our speaker from your questions. This is the time we are taking questions for 5-10 minutes. Please go ahead. So Pratik asked, pain specific scale is efficient for pediatrics, reliable or not in certain circumstances.
For my, I think pain specific scale we only for adult only they mentioned that a lot of study only done in adults only. I have no idea whether it's going to applicable for pediatrics. Uh, it's only suitable for adults only because even adults also we can't. We are only assessing with the help of subjective only. We don't have a objective tool to measure the pain. But how it's going to uh, checking the same tool for pediatrics? Very difficult, madam. I'll confirm and tell you, ma'am. If anyone have idea means answer means please.
Hope, Pratik, your question will be answered. Is there any questions? If it is not, we can move to further the second session.
Thank you, sir. Thank you, Alex, sir, and thank you, principal sir and vice principal madam, and organizing madam, to give this wonderful opportunity to share my views in low back pain. Thank you, all the participants. Thank you so much. Good evening.
Thank you, sir. It's my privilege to introduce our next speaker, Mr. Bhubadi Raja, a dedicating and emerging professional in the field of orthopedic physiotherapy. Mr. Bhubadi Raja holds a Masters of Physiotherapy in Orthopedics. He is currently serving as an assistant professor in KMCH College of Physiotherapy, where he has 3 years of clinical and academic experience and is specialized in manual therapy. I invite you, sir, to give a talk on outcome measures for foot and ankle dysfunction. Over to you, sir. அதான் சார் ஆடியோ வரல இங்கே. இங்கேயும் ஆடியோ வரல. இங்கேயும் வரல சார். அவங்க அவங்க அன்மியூட் பண்ணானா பாருங்க.
Yes, audible. Yes, yes, audible. 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 Continue, Bhupati sir. Continue. Audible, sir. Continue, sir. Yes. Sir, please tell me, sir. இப்போ வந்து இப்போ
வெயிட் பண்ண சார்.
சரி.
என்ன கேட்குறேன் என்னன்னு கேட்க சொல்லுவோம்.
எனக்கு
Hello, sir. Can you hear me now? Someone asked some questions, sir. I couldn't hear from you. Yes, sir. You can continue, sir. Yes. Uh, Hello, dear participants. Please put in chat box that everybody could hear properly or not. We don't know. We are not getting a feedback whether you are getting the audio clearly or not, and slides are visible or not. Please, who are all attending? Okay. Few participants couldn't see slides, but rest of all it is okay. Yeah, just hold for few minutes. We'll start it. We'll resume it back.
கண்டிப்பா ஒரு வராமலாம் இருக்காது. நீங்க ஏதாவது ஆஃப் பண்ணியிருந்தா தான் வரும். முடியும். சவுண்ட் ஓகேனா? ஸ்பீக்கர் தான் இருக்கு. கரெக்டான வாய்ப்பு கம்மி. ஏடிஎம். வாய்ஸ் வருது. நான் பண்றதெல்லாம் வருது.
சரி. ஆடியோ வாய்ஸ் கேட்கலாம் கேட்டு பார்த்தா ரொம்ப இறைச்சலாக இருந்தது.
ஓகே மேடம், நான் செக் பண்ணி பார்த்துட்டு சொல்றேன் மேடம். ஓகே மேடம். இல்ல நான் 10 நிமிஷம் சார், ஒரு 2 செகண்ட். ஆடியோ தான் கரெக்டாக இருக்கு. தெரியலையே, மாற்ற வாய்ப்பே இல்லை. நான் கரெக்டாக தான் வச்சுருக்கேன். ஆடியோ ப்ராப்ளம் ஆயிடுச்சு. நீ பேச கரெக்டாக சார். ஸ்டார்ட் பண்ணுங்க, நீங்கள் ஸ்டார்ட் பண்ணிங்க. அவர் ஸ்டார்ட் பண்ண சொல்லிடுங்க. இன்னும் சார் எஸ் சார். எஸ் சார்.
Hmm? No, sir. No, sir. No, sir. Please.
What are the
Thank you, Mr. Bhubadi Raja sir, for your in-depth knowledge sharing with us on foot and ankle outcome measures. Hope participants will be using all these outcome measures in their workforce. Okay. If you have any doubt, you can ask to the speaker, or else you can put up your messages in a text box.
Hello, good evening, Bhubadi sir. What about any proprioception, sir? Okay, sir. Thank you, sir.
Dear participation, please bring up questions and all if you have, or else if you, there is no questions, then you can close the session. Okay, thank you for your persistent participation for today's session. We'll meet again for tomorrow at 2 o'clock. Thank you.
Kindly for same link for this one. Let us improve progress and அது ஓப்பன் பண்ணி க்ளோஸ் பண்ணியா இல்லையா? வெளியே வந்தியா இல்லையா? வெளியே வா அவ்வளோதான். ஃபுல்லா அவுட் வெளியே வா நீ. சரி.
இருக்கணும்.